the things around the VA, there's 171 VAs, or medical centers. I would say that the standardization across those VAs is rather suspect. We had pushed for a number of years to try to push a Veterans Prostate Cancer Treatment and Research Act, which finally was embedded in the legislation, the Omnibus, which passed late last year. So, Rachel, I want to ask you, start off with, what are your thoughts about the impact, and now we're going to look at implementation of this legislation? How's it affecting both? I mean, there's the administration, there's the people in the field, and patients. So I'd be interested to hear from you. What do you think about this legislation?
Well, so thanks for that question. And for me, when you have an alignment of purpose among patients, in our case, veterans, and the VA providers and researchers and Congress, you can move far very quickly. And so to me, the legislation was an affirmation that, that our work in prostate cancer was something that Congress was interested in seeing being an enduring effort and not something that, that came and went. Because to solve the problems at the scale of the VA, which, as you noted, is about, if you're talking about states about the size of Illinois or nations, you're talking Belgium, then it's going to take time and it's going to take an enduring effort. And legislation is certainly the way to ensure that longstanding support.
No, that's great. And I think in that legislation, there's an issue about that there's a research component. And a lot of that is, I think, tied to some of the trials. We have such a large population. I mean, we're looking at maybe 6 million men inside the VA undergoing care at any one time. So that's where I believe that we need to work with industry in a much more, a much closer fashion to take advantage of this, of the infrastructure and the population. And so from a Starport perspective, Alicia, how are you seeing, is there been a change with the legislation or with the research funding or the acceleration of Starport and actually the recruitment of those patients? Are you seeing any problems, or how are you feel like it's going, since that's your job, that's what you're doing, you're bringing people in?
We definitely have our challenges as far as recruitment is concerned, but we're always looking at innovative strategies. We're always looking at other trials to see what they're doing, what works for them, and trying to implement some of those same procedures within our trial to make sure that we're reaching as many potential participants as possible, because some of these trials are beneficial to them and to their care and where they are in their care. So yes, there are challenges, but every day we're working to uncover new ways of reaching, potential veterans and offering them a chance at different methods of treatment and care.
And Alicia, can you give us a quick overview of Starport? I mean, a lot of people have maybe heard about it, but how big is it and how large is it? I'm not going to steal your thunder because I know how large it is, but can you give us just some of the statistics about Starport?
Starport is a trial. Currently we have 18 sites, 16 which are active, 2 more which have recently come on board. It's across the country. We are the lead site here at Hines. We're looking for a total of 464 participants. These are veterans who have had prostate cancer in the past and has recurred and it has metastasized. We're in the process of amending our protocol, but right now as it stands, it can have metastasized to 5 sites. But we're looking to amend that just to expand our reach of potential participants. It is a 5-year trial. Participants are followed pretty closely. Every 3 months they are receiving their they're getting labs done. Every 6 months they're getting scans to check for progression. Right now we are the highest enrolling site as well, and we're up to 19 participants at Hines. So,
okay, Alicia, thanks for that. One of the things, as we talk about these in these studies and in the VA, Rachel, when we look at metrics of both implementation of this new legislation that's out there, one of the things that has been I think, talked about is the implementation of this clinical pathway. And what kind of metrics are you seeing or are being discussed about how do we measure, or how is the VA going to report back its success to the implementation of this, all of the legislation, and specifically that clinical pathway?
So one of the reasons why I am so interested in oncology, I cover all of research, as I told you as we were chatting before. I said, I cover every aspect of research for the VA. But one of the reasons I was so drawn to oncology is that it has such a strong evidence base and provides a model for how to proceed in other areas. And that evidence base is really embodied in a care pathway. If a veteran presents with this, what's the best practice thing to do with them? And the fact that we can implement that across the VA really helps to, as you said, standardize the care across this vast system of over 170 sites. So the challenges with these pathways is that they cross clinical specialties. Cancer involves, as people who have lived with cancer know, involves a lot of specialties. You may see the radiation oncologist, you may see a surgeon, you may see the oncologist, you may see so on and so on and so on and so on. And so the ownership of a pathway is really important, or the collaboration among sites. And I think where we've run into some, if we can say friction, is about the placement of the pathway. These pathways have largely grown up out of the oncology program office, which is wonderful that they've stepped forward to play that leading role. When legislation requests that those pathways be moved from one office to another, it can perhaps be counterproductive to the ends that were initially being sought. With that said, I'm absolutely a firm believer in championing the implementation of pathways, and I believe that is the only way for us to track and measure how we're doing at the scale of something like the VA.
Sure. Yeah, no, I mean, to get standardization across all of this, especially in where we're seeing 500,000 patients that have to be dealt with on a daily basis, and 15,000 new ones every year, it becomes pretty critical as to where they enter that pathway and how that's monitored and that kind of stuff. Are there efforts along with this implementation to integrate it into the EMR systems? I mean, we've seen recently some news about how Cerner's going to get a new budget, or they're under new push, or somebody else is coming in. Where does that stand, and do you see these pathways becoming a part of the digital landscape inside the VA?
So I'll preface this by saying I'm the head of research.
Right.
I'm not on the clinical side of the house, but because of our close collaboration with the clinical side of the house, I can say that the commitment to implementing pathways within the VA for cancer care is irrespective of the EHR that exists within the VA. So you're seeing them being rolled out now, and you, Alicia, are probably seeing that at Hines, and that will endure no matter what happens, in the next 5 years or next 100 years.
It'll be there forever. Yeah, right. No,
of VA care.
So, Alicia, if you're doing this day to day, do you feel like you're getting adequate training on these things are always updated, whether it's the EMRs or the new procedures or new standardization from a pathway? As a user, are you feeling that you're confident that you've got it mastered?
I wouldn't say mastered because there's always room to learn, additional efficiencies. But I will say the VA, they do have a pretty good training system in place, TMS. So they're very engaged with our training and what we know and, what we document that we know. And a lot of that is done through TMS. So I do feel that the training is adequate. Sometimes there is a learning curve, the rollout of things, sometimes just that in and of itself, may present not barriers, but just, navigational nuances. So I do think that they prepare us as well as possible. I mean, it's kind of up to us, as the individual to take advantage of everything that's out there and make sure that we're comfortable with where we are using these systems.
So all of you know I'm a patient as well inside the VA, and I will say that I feel from the patient's perspective that being able to have an integrated care team or with dispersed different types of physicians that can actually access your situation at a moment's notice. I mean, I've seen that develop over the last 4 or 5 years. And from a patient perspective, I think it's improving almost like every 6 months. There's a better solution, or there's a better treatment, or there's a better option to bring in all this disparate group of doctors that are trying to care for your cancer, to your point. I mean, you start at primary care and you end up in some, 3 or 4 different oncologists' office, right? And so to be able to go to one facility, and have all the physicians available, on a couple of floors up and down is pretty amazing. And I do say to people that today with prostate cancer, if you're not in the VA, you should be in the VA because it's the best care that you can get out there. And I wonder, maybe Rachel, from a research perspective, when we talk about metrics and putting these things in, are there people measuring how well or a difference that this is having on patient outcomes?
So
it's kind of a research thing. I'm trying to keep it to the research of are we measuring from a research perspective, are these implementations and all this effort and money and resources we're putting, are they making a difference? I mean, I guess that's kind of from a research perspective, you do it to do it better and quicker and faster.
Well, and I can speak to my experience in the lung precision oncology program, which is part of the family of efforts that kicked off with prostate cancer as the most common cancer in the VA and extended to the lung precision oncology program, which is lung cancer, unfortunately, is the deadliest cancer within the VA. And there we closely track our goals. We've set ourselves goals like increasing appropriate lung cancer screening. And we're tracking over time across the 100 sites where that has rolled out. How are we doing in terms of lung cancer screening? And does that lung cancer screening convert into identifying people earlier in their lung cancer? So, yeah, we're not here just to just to check the box on doing this or that process, but the reason that I'm so happy to be part of a research program that's embedded within a healthcare system is that your end goal is not a publication in the New England Journal of Medicine or something like that, but it's lives saved. And that I find really is a bigger motivator for me not to hit the snooze button in the morning.